So the question here is, what is the best induction therapy for patients, and which patients need dose-intensive therapy? So I'm going to answer that in two ways. And I think one is, which patients should get reduced intensity therapy versus dose-intensive therapy? And then if those patients who get dose-intensive therapy, what is the best dose-intensive therapy? And how is dose intensity defined? So I'm going to start off perhaps with the second question, which is, what is the dose that should be used for intensive therapy? So if you look at younger patients with AML, in the US, studies have been done in the cooperative group setting comparing doses of anthracyclines. The most recent study that was done looking at that is the ECOG 1900 trial, and that looked at Daunorubicin at a dose of 45 milligrams per meter squared versus a dose of 90 milligrams per meter squared in the younger patient population. And what that demonstrated is that those who got 90 milligrams per meter squared did better than those who got 45 milligrams per meter squared. It was particularly true in certain subgroups. Now, these patients all proceeded to autologous transplant as their standard of care, although they were allowed to get an allogeneic transplant as their consolidation therapy. It was particularly true in those with an intermediate risk karyotype, those with a favorable karyotype, and those with FLT3 ITD mutations. And so our approach has been to give 90 per meter squared rather than 45 milligrams per meter squared in this patient population. And 90 per meter squared is our standard dose in patients up to the age of 60 based on this data. Now, there's additional data out of the UK looking at 90 versus 60. And what they showed was that 90 milligrams per meter squared was superior to 60 milligrams per meter squared, even in those patients who got 2 cycles of therapy, because all of them get a standard 2 cycles in the FLT3 ITD mutated population. So that leads additional reason for us to consider and to give 90 per meter squared to our patients getting induction chemotherapy with anthracycline-based therapy. And it's even been shown when comparing 90 to 60 that is better up to age 70 because the toxicity is acceptable up to age 70. Now, the next question is, which patients should be getting intensive therapy as opposed to non-intensive therapy? Well, I think that we have really good data now that intensive therapy leads to toxicity in the patient population over age 75, and that the combination of azacitidine venetoclax leads to excellent outcomes in that patient population. We've also now have evidence that really in the patient population that you'd like to get to allogeneic transplant, meaning those who have a poor risk karyotype, even if they're younger, as well as those who are unfit for induction on the basis of leukemia, the most important thing is to get them into remission and then get them to transplant. And so very often, in order to optimize their opportunity for transplant, we should be thinking about reduced intensity therapy rather than high dose therapy. It's easy in the older patient population. So our general approach is that patient population over age 70. What should we be doing? Our approach in that patient population is reduced intensity therapy, and then hopefully getting them to transplant. Patients over age 75, it's unlikely, even without a transplant, that we're going to be benefiting them by giving them high dose therapy. And so we, again, in that patient population, give reduced intensity therapy. Patient population between age 60 and 70, it's really unclear. Should they be getting induced with standard therapy or with reduced intensity therapy? Really, studies need to be done. And that's because the potential advantages of standard therapy are still unknown, because there may be patient populations that benefit more from standard versus reduced intensity therapy. That is even going to be true in the patients who are fit but under age 60 but have poor prognostic leukemia, Do we really know which patient populations are going to benefit from reduced intensity versus standard therapy? Really questions that need to be answered. But there is room for improvement in terms of standard therapy, both in terms of likelihood of response in the patients with poor prognostic disease and likelihood of toxicity in the patients who are older or unfit at the time of diagnosis. And so we really are looking forward to studies that will help us answer those questions.